morning and welcome to another session of Heart to Heart. It's my pleasure to welcome Dr. Jorge Castellanos, one of my colleagues, who heads our structural heart program here at Our Lady of the Lake Regional Medical Center. Jorge trained in El Salvador, went to medical school there, and subsequently has trained at Miami, Tulane, and most recently at Swedish Heart in Seattle. So welcome, Jorge. And thank you for really developing a phenomenal structural heart program here in southeastern Louisiana. Tell me a little bit about what you do and what is the structural heart program?
Well, thanks for having me first, Danny. So structural heart disease is a relatively new subspecialty in cardiology. And structural heart diseases are diseases of the larger structures of the heart. The cardiac valves, the doors that separates the chambers of the heart, the walls of the heart, the muscles of the heart, those larger structures, that's what we treat. And this usually requires a very extensive evaluation that requires a team of people that includes advanced imager cardiologists, interventional cardiologists, surgeons that at the end treat the patient as a whole. And a lot of the structural heart diseases used to be treated with open heart surgery back in the day, and now we have the ability to treat these diseases with minimal invasive techniques. So that's kind of like the big concept of structural heart disease.
Very good. That sounds exciting. And I'm glad you have a team of people surrounding you. So tell me a little bit about some of the patients that you've seen recently with quote unquote holes in their heart, and what is an atrial septal defect, and I understand you've been able to repair some of these recently here in Baton Rouge.
Yeah, so when someone has a hole in their heart, they can be born with it or they could acquire it. And we can use the same minimal invasive techniques to close those holes in the heart. One of the most common is when there's a hole between the two upper chambers of the heart. That's usually something that the patients are born with. But we also have treated patients that have had a heart attack, that the heart attack caused a big hole in the lower chambers of the heart, and we have been able to close that hole and prolong those patients' lives.
Right. I understand very recently you had a very sick gentleman who was transferred into this hospital for you to do specifically that, and you were able to repair a pretty extensive hole in. Yeah.
That's correct, and those patients are very, very sick, and if we didn't have this ability, those patients wouldn't survive.
And that patient needed a lot of specialist care, so intensive care unit physicians, cardiothoracic surgeons, and a team of specialized nurses that helped you get that patient out of the hospital.
And obviously, to decide what size plug or you need to use, you need someone that is able to measure that and look at the hole. So also the advanced imaging cardiologists are a very important component.
And what are some of the new imaging techniques that you're using in structural heart disease?
Yeah, so we use an entire variety of imaging modalities, including ultrasounds, echocardiography, x-rays, different types of x-rays, plain fluoroscopy, and CAT scans as well. But we also use MRI as well.
Right, so a wide array of imaging techniques. Moving on to people that cannot take blood thinners for conditions, a very common condition, atrial fibrillation. You've been able to introduce some new ways of treating these patients, sparing them from having to take blood thinners. Tell me a little bit about that.
Yes, so patients with atrial fibrillation or irregular heartbeat, as you know, they have 5 times higher chance to having a stroke compared to patients that don't have atrial fibrillation. The standard of care for those patients is to put them on a blood thinner. But not everyone can take those medications because patients they bleed, they fall, medications are expensive. There's a long list of reasons why you look for an alternative.
And recently, I had a patient that I sent to you who had had a subdural hematoma, collection of blood, having had a fall, and was on a blood thinner. And since then, we've been able to get her on a left atrial appendage occlusion, and she's doing extremely well now. But tell me a little bit about how you assessed that patient and what you did for her.
Yeah, so in that group of patients that are not ideal candidates to take those blood thinners, we look for an alternative. And we know that 90+% of the patients that develop a stroke in patients with irregular heartbeat, they form a clot in the left upper chamber of the heart in a small pouch called the left atrial appendage. So we target that area of the heart, and we can put a plug in that particular area, and by doing that, reduce the risk of stroke to close to 90%. And when you compare those patients that are taking a blood thinner and the patients that you put an appendage closure or you close their appendage, they have about the same rate of stroke, but you don't have that risk of bleeding.
And you do everything, what previously would take an open sternotomy or cut through the sternum, you're able to do this now using less invasive techniques.
Yes, this just requires a tiny incision in the groin. The majority of the procedures that we do are minimally invasive. We go with a small catheter in the groin, and to deploy that plug that we're talking about, we just go on the right side of the heart, get across, and target the area and put the plug in.
Valve disease is a common cardiac condition, so people that have either leaking valves or narrowing in their valves. You've been able to introduce some new techniques to this community treating leaking mitral valves. Patients that previously would have either gone to surgery or not able to go to surgery for other health conditions, you're able to treat now and prolong their lives, giving them a better quality of life. Can you tell me a little bit about the mitral valve techniques that you've introduced?
Yeah, just as a basic concept, the heart has different chambers or different rooms. Those rooms are separated from each other by a door, and we call those doors cardiac valves. There's only two things that can go wrong with the door. Either the door doesn't open or it doesn't close. So exactly the same thing happens with the cardiac valves. Either the valve doesn't open or the valve doesn't close and it leaks. And in the mitral position, that's the valve that separates the two left-sided chambers of the heart. And one of the most common pathologies in the mitral valve is a leaky valve. And when the valve leaks, the problem that happens is that all the blood that is supposed to go out of the pump comes back to the left upper chamber, and that's connected straight to the lungs, and the patient's flood.
Yes, your patients may get shorter breath, have swelling in their ankles, abdominal bloating. So how do you go about trying to help these patients?
So obviously, if the patients are good surgical candidates, the standard of care is still open heart surgery. Okay? But there's obviously a group of patients that are definitely not good surgical candidates, very high risk for surgery. So in that group of patients, we can use minimal invasive techniques. And one of the things that is approved by the FDA is the mitral clip. This is a transcatheter mitral valve repair technology. It's not a replacement, it's a repair. Again, similarly to the other procedures that we do, we go through the groin, small incision in the groin, we get up to the right side of the heart, and then we get across and target the mitral valve. This mitral clip is like a clip that has two arms, and each of the arms can independently grab each of the leaflets of the mitral valve. We target them, grab them, and then close it. So we target the area where the valve is leaking the most, and we will close that particular area of the valve. The valve would open on each side, but we will reduce the amount of blood coming backwards.
Great. And patients feel better and do better. They're able to resume and activities of living and have a better quality of life. When you're doing this, when you're assessing a patient, you do this in conjunction with a cardiothoracic surgeon, and both of you together make the decision to determine, is the patient better served with surgery or with the structural heart disease program, less invasive techniques. And then you move forward with doing that in a combined fashion. So it's a combined effort, I understand.
It's a multidisciplinary approach, without any doubt. The surgeons are an essential part of the team. And if we think that the best thing for the patient is to go for surgery, that's what we would recommend as well.
And then after the procedure is performed, you have very careful follow-up. You see the patients on a regular basis, and then many of them go on to cardiac rehab to help them get back to a better
Yes,
standard.
every single patient that is treated with a transcatheter therapy is enrolled in a registry, and as a requirement, it's important for us to follow them at least after discharge 1 month out and a year out as a minimum requirement.
That's great, yeah. And in a new and exciting field like structural heart disease, almost every month we see new developments, and I understand you're heading up a research program for structural heart disease with some exciting new things. What do you see in the future? What can we expect?
Yeah, there's a lot out there in trials. I think that the mitral and tricuspid are valves are very exciting technologies out there. I'm excited to announce that we are now part of a transcatheter mitral valve replacement clinical trial called the ENCIRCLE trial. This is a transcatheter mitral valve replacement, not repair, replacement technology. Minimum invasive. Again, we go through the groin, small incision, we get from right side of the heart to left side of the heart, but instead of putting a clip, we replace the valve without opening the chest. So it's, it's very, very exciting.
Dr. Castellanos, can you show me what a left atrial appendage occlusion device looks like and where it would fit in the heart?
Yeah, so we have 2 devices that are approved by the FDA for left appendage occlusion. The traditional Watchman device and the most recently approved, the Amulet device. Both of them do exactly the same thing. They're both very easy to compress, as you can see. They actually come into the package, compress. And this comes into the catheter like this. And the whole point of this, let me use the Watchman, is to kind of come through the groin, get up to the right side of the heart and get across, and the appendage would be somewhere around here in the left upper chamber of the heart, and we would just put it somewhere like this.
And that covers any clots that could be formed, preventing them from getting out and traveling to the brain to cause a stroke or something
That's
like
correct.
that.
That's correct.
Very good.
It would take some time for the device to be completely covered by new tissue. In those first few weeks, we do need to put the patients either on an antiplatelet medication or a blood thinner. But once the device is completely covered by new tissue, I mean, there's scar tissue on top of that.
Dr. Castellanos, tell me a little bit about this clip that you place on the mitral valve.
Yeah, so the mitral valve is the door that separates the 2 left-sided chambers in the heart, so left lower pump and left upper pump. And this valve has 2 leaflets. So you can see it's supposed to open and close, open and close. So
I understand they're named after a bishop's mitre, the hat the bishops used to wear.
That's correct. And the whole purpose of the mitral clip is to, this clip has 2 arms, so the whole purpose of the clip is to grab those 2 leaflets independently with the clip, so the valve would go from a single orifice valve to a double orifice valve. The valve would no longer open in that area, but that's the area where the valve was leaking. By doing that, we will reduce the blood that is coming backwards to the left upper chamber of the heart and reduce the pressures in the lungs as well.
So less shortness of breath and less abdominal bloating or feeling full and less swelling in the ankles.
That's correct.
Very good. Well, thank you, Dr. Castellanos. That ends our session for Heart to Heart. I look forward to seeing you at the next Heart to Heart session.